Welcome everyone to The Explainer. Let's just jump right into it. Today we're tackling a critical update on acute pulmonary embolism evaluation. For those of us in the emergency department, internal medicine, critical care, and surgery, the daily challenge of suspected thromboembolism is absolutely relentless. We see it constantly. So today we're zeroing in on exactly why and precisely when we should, or more importantly, shouldn't be ordering a D-dimer test.
Here is how we're breaking this down today. First, we'll look at the over-testing problem, then dive into mandatory pretest probabilities. From there, we'll map out the D-dimer pathway, pinpoint exactly when D-dimers lie to us, talk about using adjusted thresholds, and finally, wrap it all up with a summary of the 2026 guidelines.
All right, part 1, the over-testing problem. Let's talk about why we are doing way too many CT scans.
In the ED and ICU, we are constantly seeing patients with pleuritic chest pain and dyspnea. It's our bread and butter. But here is a truly sobering statistic. Less than 10% of patients evaluated for a PE actually end up being diagnosed with one. Less than 10%. That single number completely exposes our over-reliance on testing and the honestly dismal diagnostic yield of CT pulmonary angiography. When we just blindly order tests, we're exposing patients to completely unnecessary radiation and contrast risks without actually improving our accuracy. We desperately need a better filter.
And that brings us to Section 2, Pre-Test Probability Rules. This is that essential filter we've been looking for.
To stop this over-testing cascade, quantifying our clinical gestalt is absolutely critical. Validated tools like the Wells or Revised Geneva scores are our bedrock first step. Whether you're working up a suspected PE or a DVT, these scoring systems force us to systematically categorize patients into low, intermediate, or high-risk buckets based on hard clinical signs. You absolutely must calculate this pretest probability before a D-dimer is ever drawn. No exceptions.
Now, for those patients who fall into that low clinical probability bucket, we have an incredibly elegant tool at our disposal, the PERC rule. If your patient meets all 8 of these rule-out criteria, things like being under 50, a heart rate under 100, and oxygen saturation above 94%, you can confidently rule out a PE without a single blood draw. You're just done. No further testing required. It's a total game changer for efficiency.
Moving right along to Section 3, the D-dimer pathway, and figuring out exactly when to actually test. The updated 2026 AHA branching logic makes this incredibly clear. D-dimer testing is exclusively reserved for patients with a low or intermediate clinical probability. If your patient has a high clinical probability, meaning a greater than 50% chance of a PE or DVT, you need to completely bypass the D-dimer and go straight to diagnostic imaging. Ordering a D-dimer for a high-probability patient is a classic rookie mistake, mainly because a negative result just won't safely rule out the clot anyway.
We really have to respect the fundamental nature of the D-dimer. Yes, it's a highly sensitive biomarker of blood coagulation. We're talking greater than 95% sensitivity, but its specificity is abysmal at less than 40%. It is a massive diagnostic trap if you're not careful. It only gives you a high negative predictive value when it's deployed in that low or moderate pretest population. Always remember, it's a rule-out test, never a rule-in test.
Which leads us perfectly into Section 4, when D-dimer levels lie. Let's look at the Do Not Test roster.
The reality is, the D-dimer is naturally elevated in tons of physiologic and pathologic states. If your patient is older, has an active malignancy, had surgery in the last 4 weeks, or has severe chronic kidney disease, an elevated D-dimer is practically guaranteed. The exact same thing goes for autoimmune diseases, atrial fibrillation, and heart failure. In these specific patients, drawing a D-dimer is just an expensive, time-consuming detour on the way to a CT scan. Do yourself and the patient a favor and avoid it entirely.
Pregnancy is another major confounder. D-dimer naturally rises across all trimesters, which is exactly why the guidelines mandate a pregnancy-adapted years algorithm, really leaning heavily on unilateral compression duplex ultrasounds first. And if imaging is completely unavoidable, the ASH guidelines strongly advocate for VQ scans over a CTPA. Why? Because it drastically minimizes radiation exposure to both the mother and the fetus.
All right, Section 5, Adjusted Thresholds, and how they are saving scans.
For those patients where a D-dimer actually is appropriate, it is time to abandon that archaic universal cutoff of 500. Implementing the age-adjusted rule for patients over 50, where you simply take their age and multiply it by 10, drastically and safely reduces unnecessary scans. Alternatively, you can use the years algorithm, which allows for a threshold of 1,000 if 0 criteria are met. The 2026 data is completely conclusive on this.
Utilizing these advanced thresholds does not increase the rate of missed VTE events, but it saves countless patients from unnecessary radiation.
Let's pull all of this together in Section 6, the 2026 Key Guidelines Summary.
The latest AHA, ESC, and ASH guidelines are completely unified around one core message. We have to optimize our resources. The AHA introduces structured acute PE clinical categories, meaning those low-severity patients can be safely discharged home right from the ED, often on DOACs instead of VKAs. The ESC is strictly mandating those age-adjusted D-dimer thresholds we just talked about, with CTPA as first-line imaging. And ASH is holding firm on their preference for VQ scans in pregnancy. It's a very cohesive, specialty-wide push towards smarter, less invasive, and highly structured care.
So as we wrap up this explainer, I want to leave you with a direct challenge. Permanently shift your clinical behavior starting today. Stop the knee-jerk labs. The very next time you suspect a PE or a DVT, what are you going to do first? Are you going to immediately order a D-dimer, or will you calculate that pretest probability? Commit to the Gestalt, deploy the PERC rules, and start using adjusted thresholds. By doing so, you're going to deliver much more precise, incredibly safer, and highly effective patient care. Thanks for joining me on this deep dive.